Right, welcome back, everybody. I hope you've had, well, some semblance of a coffee break and you enjoyed your hands-on session. Right, we're going to talk about DVT, deep venous thrombosis, venous thrombosis ultrasound now. I've done my conflicts of interest, so I don't need to wobble on to you about that anymore. And I'm sure your English, as I said to Marco, is better than mine is, so I hope I'm speaking clearly enough and you can understand me. And fair play to you all for listening in English, because some English people don't speak any other languages. So there we are. So well done to you all. Anyway, enough of that. So if you scan the QR code here, you can follow me on Twitter, and there's all sorts of ultrasound shenanigans going on there, tutorials and all kinds of other things like that. So I do plan to do a tutorial on this exact subject in the next week or so. So you will see that. So I'll link you all in if you follow me. FUSIC, as you see on the left here, this is our focused ultrasound in intensive care. And I'm a member of the committee in the UK on this. And we have got a fantastic program of whole body ultrasound, all modularized. So please do take a look. Okay, so on with the talk. So DVT ultrasound, I think is something that is too often missed on the ICU. And the reason it's missed is because we don't consider it to be particularly important a lot of the time, but we certainly do when we see changes in other modalities of ultrasound. But why is it important? Well, it's a very relevant subject because patients come to harm from deep venous thromboses and, at the worst, pulmonary embolus resulting from it. So I'm going to discuss the basics, our FUSIC protocol, and some caveats and pitfalls basically throughout the talk, and you'll understand what all this is about shortly. Now, I apologise for the frame rate. I think on your end, it is slightly glitchy, as I'd say, so I'm very sorry about that. I'll put it on YouTube if I get time, but bear with me, because there's lots of clips and stuff in my talks that's probably sapping the bandwidth a bit. Anyway, so the background, DVT and its sequelae is a big subject in the ICU population. 5 to 10% of all ICU patients will suffer from a DVT, and we don't pick it up a lot of the time. And it does account for a large number of ICU-related deaths from pulmonary embolus resulting from the DVT. This is why we're so hot on venous thrombosis prophylaxis in hospitals, and I'm sure you guys are probably better than we are in the UK at this. Goes without saying, frankly, with lots of things, but it is a big cause of preventable hospital death. So the problem we've got in the UK certainly is our VT prophylaxis use is very variable, and we have pathways and we have all kinds of things that even when used, sometimes patients still slip through the net and suffer from a deep venous thrombosis somewhere. So clinical examination's got a sensitivity of between 60 and 96%. So it's very vast, and its specificity is even worse, 20 to 72%. And even if we apply risk stratifications, for example, the Wells score, and you can Google that, it's not particularly valid in the critically ill. And the reason is because the act of being critically unwell in itself is a significant risk factor for thrombosis. And the gold standard for DVT is obviously contrast venography, send them off to the department from a place of safety to one that's less safe. So that's a faff, it's not easy. So comprehensive ultrasound of the lower limb, and if you get good views, it's actually considered equivalent to a contrast venogram and is the gold standard in many hospitals. And recent evidence has actually demonstrated that even the limited protocols, such as the one we're going to talk about shortly, have a 99% sensitivity and specificity compared to whole leg triplex scanning. And I'll tell you what triplex is in a short while. So I call this Probeology, as you have knobology on the machines, giggle, etc. But Probeology, simple. We use a linear probe, high frequency, low depth penetration for most of what we need to look at. And if you've got the slightly larger patient, you might want to use the curvilinear probe, which is pretty good as well to use for finding DVTs. Now, here we go, moving on to some glitchiness in a second where the slides probably don't show too well, but I apologize again. So you've got to have the appropriate preset, and most machines will have venous or vascular. So do select that and optimize your depth, your gain, and your focal point. And also, you may as well fill the screen with the target area. There's no point in not filling the screen and having everything that's absolutely minuscule there. Just fill the whole screen, zoom in on what you think you need to be looking at. The images have to be the right way around. What I mean by that is we stick to a standard imaging convention, and that is that of radiology. And we'll discuss that a bit more in the next sections. But as long as you know what lateral and medial is on the screen, that's the important point to make, because then you get your anatomical relations. This is the typical frog leg position that you put the patient's leg in. This is the right leg. And we're going to scan from the top groin crease all the way down to behind the knee. And if you want to get even better at this, you can scan even further down from the back of the knee down to the back of the ankle. But we rarely need to actually do that and go down that far. This is enough. So this triplex scan business, what is it? So firstly, we need to identify our structures. Once we've done that and we've got the anatomical relations correct, we can then apply the triplex. So the first of the triplex is two-dimensional ultrasound. That's one. The second is color flow Doppler. And the third is spectral Doppler. So there's your three. That's what triplex is. So the color flow can differentiate artery and vein. And then we're going to start compressing, and I'll show you how we do that. We're going to compress all the way from the groin crease all the way down the leg. And you'll be doing that in your hands-on sessions, hopefully. And if you've already done it, I apologize because I'm not there. And then you can apply pulse wave Doppler to show venous versus arterial flow. And it's fairly obvious. Now, there's a thing called augmentation. I think you call it the same thing where you guys are, but all that is you get an assistant to squeeze the calf or the leg further down distal from where you put your probe. And what that does is it squeezes blood up towards the probe if you've got a patent vein, and we'll show you that in a minute. So here we are scanning the groin crease under the drapes, and we dip the tail down to see the saphenofemoral junction, scan for the common femoral, and we move down the leg all the way to the back of the knee, as I've just described then. I hope this is showing okay and it's not too jumpy. It's probably jumpy all over the screen for you guys. I've said to Mark, it must be your bandwidth. And then we go to the back of the knee and we stop there. Now, compression, it's quite easy. We do the same thing we've just done, but we press in. Each stage, press in, press down, scan 2 centimeters further down, press down again. Now, when you get to the back of the knee, put some pressure on the front with your hand, and it stops the leg from moving all over the bed, and then compress inwards as you push on the front of the knee, and that will give you good popliteal compression. So here we've got quite a substantial venous plexus down the lower limb, but we're only really focusing on a few of those vessels, and I'll just show you which ones we're interested in. So if you look on this image here, there's lateral, medial's the other side. There's the common femoral vein, going into the femoral vein, and then it terminates and travels down to the saphenous and great saphenous further down the leg and curves off behind the knee into the popliteal. So the femoral vein actually terminates partway down the distal femur. And if we show the lower limb veins, same kind of thing, hopefully not too glitchy for you guys, but there they are. There's lateral again, and we see the popliteal wandering down. And then laterally is the anterior tibial, and the posterior tibial is medial. Now, as I said before, sometimes we rarely scan down to this level. We usually stop about here, and it's pretty sensitive from here on upwards, or there downwards to there. If you want to get very funky with things, you can scan further down the knee, but I rarely do that, if I'm honest, because you find most things further up. Okay, so let's take some focus on the big pipes. We should, by convention, start at the umbilical level, looking at the IVC, which should be on the right, and the aorta, which should be on the left. And if we then put the probe on, we move down, we can get the bifurcation of the aorta into the iliacs, and you'll see the IVC to the side, and it looks like this. Again, I hope this is okay for you guys. You can see here the vertebral body and the acoustic shadow at the back. There's your IVC to the right. Here's your aorta, and there it goes into the iliacs. So we're at the level just there, going up to down, up to down. Now that's the first scan we should, by convention, look at. But actually what we do really is move on down to the groin crease at this level here. And we see this. And what we're going to look at now is the place where we all put our big lines, our vas caths and so forth. You've got the common femoral vein and the femoral artery sitting there. And I remember it usually as nerve, artery, vein, and Y fronts, underpants in the middle. So nerve, artery, vein, the Y fronts of the underpants in the middle. That's a sad UK thing. I don't know whether you guys have Y front pants, but there we are. That's a different topic. And if we just zoom in on this level here, we get the saphenofemoral junction. I want you to focus on this because this is now the point where we get this Mickey Mouse thing, and we all love silly things in ultrasound. It helps me remember, certainly, but there's your common femoral artery laterally. There's the femoral vein, and there's the saphenous vein. And look, there you go, common femoral artery, femoral vein, saphenous on the edge. It's Mickey Mouse's head. How utterly amusing. Here we are compressing it now. You can see that the veins are disappearing out of view, and the artery remains patent. Veins disappear, artery remains patent and is still pulsing. So there's a compression at the saphenofemoral junction. That's point one, really, that I would scan. And then we move on down and we look at the femoral vein, and it sits next to that femoral artery. And that's the point where we go with our vas caths, as I mentioned before. You've got the femoral vein there, the femoral artery there, and it's nerve, artery, vein, and the Y fronts of the underpants in the middle. I am very sad, I'm sorry. Too many children. Now, and if we compress, you can see obliteration of the femoral vein, maintaining the artery at the top. And this is a lymph node you can see here. But there's the vein being compressed in the artery, and there's the femoral vein running on down. It terminates behind the distal femur just there. Here's pulse wave, colour flow Doppler place, and you can really see. By the way, you don't always get blue and red traces, so don't get transfixed on the direction of flow and blue and red. The point is that this is less pulsatile than that one, which is the artery. And yes, they are by convention showing red and blue for arterial and venous, but there's almost a duplex part. You've got 2D and colour flow, so that's 1 and 2, so that's a duplex. Moving on down to the saphenous vein, and that courses off more medially to the femoral. And it sort of looks a bit like this. We're catching it and then moving on down the leg, but you can see here it travels on down, and then this one, as we minimize it, goes all the way down the leg to almost above the medial malleolus, whereas the femoral terminates behind that distal femur up at this point here to become the popliteal. And what we're seeing on a scan as we move up to down is this kind of image, and we're compressing here, and you can see the same sort of picture going on as we move down to popliteal fossa, etc., etc. But you can see that the artery gradually moves more medially as it goes over the top of the vein we're looking at. Here's the popliteal vein, and I do lots of my IPAC blocks for knee replacement surgery at this level, because you go behind that artery and you can get onto the femoral condyles and drop in over all the posterior nerves supplying the knee, genicular nerves and so forth at the front. But you can scan down into this fossa, and this is the image we get from here, a lovely pulsatile artery sitting and the vein above it. So there's the vein and there's the artery down there, and we'll show you what compression looks like in a GIF. And if we then minimize all of this across, I'll show you what course the popliteal vein has. It's a fairly dull one and it's quite short, as you can see. Let's just take all that away and you'll be able to see as it travels around what we're looking at behind the knee. So here we are. This is the popliteal vein. So it's got a relatively short course where it terminates off. Important not to miss. And as you compress, you can see obliteration of the vein at the top and the arteries maintaining its patency at the bottom. Vein there, artery at the bottom, and this is us compressing it here. Now here is the other part, which is the pulse wave Doppler. I don't know if you can appreciate that on your screens. Apologies if you can't. I'm placing the gate over the vein just there, and you can see that the signal is fairly dull and boring. We certainly haven't got this whooshing of an artery coming across. It's dull and it's venous, and that is what a venous pulse wave Doppler trace looks like. To put it all together for you in one kind of graphic, I guess, here's the top section, the IVC and the iliac bification. That's executive point 1, but it's very difficult to compress structures here. That's why we rarely look. And this is also why iliac DVTs are sometimes missed, and IVC ones, well, you'd be unlucky to get one of those. Point number 1 really in this scan is that saphenofemoral junction, the saphenous vein, femoral vein and femoral artery, and the Mickey Mouse head showing there. Moving on down again, and you'll do this in your hands-on probably, and you'll be bruising your models as you compress the living daylights out of them shortly. The common femoral vein, common femoral artery, nerve artery vein Y fronts going from lateral to medial. And then round the back of that knee with anterior compression, posterior compression, the popliteal vein and the popliteal artery shown nicely there. And again, I'll try and get these uploaded to YouTube so you can all download them and keep them and so forth and so on. Okay, here we go. Now moving on to some interesting scans. So here we've got application of our augmentation. This is what I was on about before. So if you can imagine, we have an assistant squeezing the calf and we're scanning above that level onto the common femoral vein and the artery. And you can see here a flash of red. That's a squeezing. There you go, whoosh, squeezing. We let go, whoosh, and we're squeezing. And on the trace, you see this augmentation spike in the venous flow as we increase the pressure. That means the vein is patent, certainly above where the assistant is squeezing. So that's augmentation. You can do that as far down as you like. Now, if you look here, we've got the common femoral artery there, or the femoral artery and the femoral vein. You can see very little flow. There's the artery pulsing. You've got a little smidge of flow at the back. There's a DVT in here. Even without compressing, because it's blocked, there's no flow. And here's the common femoral vein again, being compressed, and you'll see here there's a DVT, and you can see them quite nicely when you compress. They suddenly appear to be a bit clearer. Now, I wouldn't advocate vast amounts of vigorous compression over a DVT too much, because you could shower it off and send it elsewhere. And you can see here, clearly, the vein is open at one stage there, and then we compress it. It looks fine. Then you compress it, and suddenly you will see this DVT appear there. There's the artery there. There's the DVT. Quite obvious. And hopefully the frame rate's not knackering the images here for you. And again, here we've got the popliteal fossa. There is the popliteal artery at the bottom, and there is no flow and the semblance of an echogenic DVT sitting in this popliteal vein there. And there's the flow around the edges as the venous flow is trying to skirt around the back of it. Just to demonstrate that compression, big patent vein, something funny there, compress it, it disappears partially, but there's your DVT, and there's that artery pulsing away, shouting, "Hi, I'm here, where's my vein?" Not there. Now, there are some mimics that we need to know about. So a fresh hematoma might look a bit like a DVT, but the echogenicity of it is slightly different. The morphology is different, and they're not the same thing. We don't need to go systemically anticoagulating someone who's got a hematoma, say after an operation or a trauma. You've got to be very careful. There may still be good flow around a hematoma. Lymphedema and edema, there'll be full flow in that vessel, but it does look a bit strange, a bit swollen, and slightly iffy, if you like, on the scan. But you should have pulse wave Doppler flow on that as well. Cellulitis, the same thing. Cobblestoning and so forth might give that away further up in the superficial tissues. Pseudoaneurysms. So communication, and the classic we get with pseudoaneurysms are intravenous drug abusers who come and use the femoral area. We can get a communication between the femoral artery and the femoral vein, and indeed a pseudoaneurysm forming in the vein that actually looks like a DVT because there's not much flow in the aneurysmal section. And Baker's cysts are something that's relatively common behind the knee, and we'll show you what they look like. They can mimic a DVT. And lymph nodes as well. I'll show you some of those in a minute. And there we are. This is a lymph node at the top, fairly big, polymorphic, echogenic structure in the middle, and around the edge there's some hypoechoicity, if you like, where it looks black with fluid. And the lymph is actually a viscous flowing material, but you get little bits of sparkly flow around the edge of it, and it's fairly big, and it does compress, you can see. And there's the artery below. So a lymph node can look a bit like a DVT till you compress it and you put some flow on and see some around the edge. And also it's probably in a different position because there's the vein compressed. There's your artery. See the vein? It'll reappear in a second, but it definitely compresses off the screen. There it is, and compresses right down. Lymph node remains. Here's a Baker's cyst. Cystic or polycystic looking structure, hypoechogenicity in the middle. And if we scan it in a long axis view, there are sort of little pockets of loculation Looks a bit cobblestoney, but it will compress. You can see us pressing on it, and it does compress somewhat, and the remaining bits here. Now, if you put flow on it, there wouldn't be anything to see in that. So putting things together, let's say we've done an apical four-chamber and we see this. This is a dilated right ventricle and right atrium. And this here is a hypercontractile apex and a very sort of dim-looking, trying its best base. Now, this is McConnell's sign, you can see here, and this is a scan from my friend Ashley Miller, which he kindly shared. Flipping this into the parasternal long axis, enlarged right ventricle, with a dipping septum which impinges into the left ventricle on each systolic contraction, very enlarged. So we're thinking there's something not right here. Going to an RV inflow view, right atrium, tricuspid valve, right ventricle, and you can see a big struggling right ventricle here and an enlarged right atrium. Let's put some continuous wave Doppler through that tricuspid valve, and look, we've got a Vmax of 3.13, which is vastly increased, suggesting tricuspid regurgitation, i.e. a pressure overload phenomenon, which might be acute in the heart. So why is that? Well, let's scan and look, we've got a dilated IVC that's not contracting down at 2.1 centimeters. And here we are, when we've looked further down the leg, there is a classic femoral vein DVT, the artery patent. So we've just found out why the patient's got a pulmonary embolus, which is likely causing the TR because the DVT set it all off originally. Here's flow over the top, and there's the clot at the bottom. So this patient's had a femoral DVT, which has showered off, causing a pulmonary embolism, which has caused the heart problem. So you see, you can put all of your ultrasound together beautifully to build a picture using your detective work with insonation as to why the patient was suffering and why they may have come in acutely unwell and hypoxic with type 1 failure. And another one here, this is actually an axillary vein DVT. This is an area we rarely look at, but here is one for you there, with a painful swollen arm in a patient on the ICU. And there is some viscous blood flow, almost rouleau formation, and the clot. And here it is on the short axis, blatant when you compress down. There's the axillary artery, and there's that vein that's bunged up with clot. And here's some colour flow, venous flow, and it stops distally. There is no more flow because of that big DVT. So let's not forget that DVTs happen elsewhere. And we're nearly done. So how accurate are we? Well, emergency medicine studies have demonstrated that the sensitivity is around 90 to 100%. The specificity is 75 to 99% of this scan protocol. Pretty good. Critical care studies have almost matched this, saying we've got a sensitivity of 86% and we've got a specificity of 96. So it is accurate and it is very helpful when it is performed properly. And I don't think it's over onerous to do this. It's scanning of basic anatomy and compression at 2 centimeter points down the leg, applying your color flow and applying your pulse wave Doppler. And it may make a big difference. As I said, we can miss iliac DVTs for the reason we don't often scan high enough and we don't compress at that level. Fresh thrombus can show up as different morphology. And upper limb DVTs, we rarely scan there unless we're putting a line in or something, doing, for example, a PIC line, and we happen to find a problem. So in summary, focused lower limb DVT is highly specific and sensitive. So let's do more of it. Let's start from the femoral vein at the saphenofemoral junction and work our way down. Compress 2 centimeter points up to the popliteal trifurcation. We don't need to go much lower than that because DVTs aren't actually that common further down. Use color Doppler to differentiate the artery in the vein. Put your pulse wave Doppler on and then try your augmentation with an assistant to see if there's a DVT you've missed. Thank you very much for listening again, and thanks again for the invite to talk to you guys. I wish you all the very best for your future with ultrasound and in your careers as well. Please scan the left-hand side for a really nice paper by Carty et al. On DVT ultrasound. The middle one is to have a look at our website with lots of POCUS on it. And on the right-hand side, please scan that to take a look at our FUSIC, Focused Ultrasound Intensive Care in the UK. See if you're interested. All the best to you all. Take care and thank you for listening.
So thank you, Jonny Wilkinson, for this.
So that's a really good question, actually. So basically, if you see signs, so the question was, when a patient has a PE, how often do we find a DVT that was responsible? Is that the question? Yeah. So I think this is an interesting question, because if we are very suspicious of a PE, the problem is if it's a massive PE, we thrombolyze. So therefore, when we scan and look for a DVT at that point, we're not going to see one because it's usually lysed its way out. If we're very, very vigilant with our scanning protocol, as Ashley Miller was with his there when he found McConnell's sign, then he looks, suspects a PE highly because they're hypoxic, then finds a DVT. Well, that's a more common situation, because at that stage, we probably haven't made the decision to treat them with thromboprophylaxis treatment dose or thrombolyze. So if I could give you a percentage of how many DVTs we find when we suspect a PE with other modalities of ultrasound, I can't, but you can't exclude it. You must look for a DVT if you're suspecting a PE. That's my answer, but I couldn't give you a percentage, really. There's probably a paper that tells us that, and I think there may be a quote in Carty's paper on that left-hand QR code. Does that help? No problem. Any other questions?
Questions also here?
No? Everyone happy? Well, hopefully that was helpful. Take care, everybody, and thanks for listening.
Thank you, Jonny.
Enjoy the course.
So that was it for the moment. So we will now have a lunch break until 1 p.m. But first, we would like to take a picture with all of you in the inner courtyard, just here behind the big windows. So we would just ask you to get out there right now with your FFP2 masks on, so that we can take this picture, and afterward we would ask you to return to your seats, and then row by row just go out, and then you will get your lunch packet. Thank you.